I'm an educationalist. I'm Professor of Geriatric Medicine at Monash University, and I'm Clinical Director of Geriatric Medicine at Eastern Health. And as you can see from my scrubs, I have a clinical role. I've finished my ward round this morning and came here to be with you. So I work to improve the health-related quality of life of older people. That's what I do as a clinician. I also do that as an educator and as a researcher. And through my academic affiliation as Professor of Geriatric Medicine, I aim to provide education that enables change in older people's care and also in their behaviour to improve their lives. So that's what makes me tick, and that's really why I'm here today. So I'm going to very, very briefly reinforce what you've already heard from Kirsty about the introduction, provide an introduction to dementia, talk a little bit about the fact that there are many different types of dementia, reinforce that dementia is not a normal part of aging, talk about the fact that dementia is not inevitable, and then address the really big question for all of you here: what can be done to reduce the risk of dementia? So we had Kirsty tell us that dementia is an umbrella term that encompasses many different types of dementia. The most common type of dementia is Alzheimer's dementia. That accounts for about a half of all dementia. And then there are other many other forms of dementia. The next most common are vascular dementia, which is really when there are many, many tiny, tiny little strokes that affect the brain, or Lewy body dementia, frontotemporal dementia, and many other types of dementia. So when we talk about dementia, it's worth being aware that some things apply to some types of dementia and other elements apply to others. Nonetheless, there are some general principles that I'm very happy to share with you. What are the risks for dementia? Well, the biggest risk for dementia is advanced age. Can anybody tell me how to modify that? Obviously, that's not a modifiable risk factor. Nonetheless, as you all know, dementia becomes more common as people become older, and it's of the order of less than 1% in people below their mid-60s, and then it increases to 5 to 10% of people in their 70s, and about 30% of people in their mid-80s and upwards. So you can see that the prevalence of dementia is exponential. So it doesn't just increase linearly, but it increases exponentially with increasing age. But as we've all agreed, that's not a modifiable risk factor. But there are modifiable risk factors. One of those is the vascular disease risk factors: smoking, high blood pressure, and abnormal blood fats. So these are vascular risk factors. They certainly are important for vascular dementia, and increasingly we understand they're also important for other types of dementia, including Alzheimer's dementia. There is another risk factor which is hard to modify, and that's selecting your parents. There is a genetic component to dementias. Some dementias are strongly genetically determined, but in most instances, this is a relatively clinically unimportant element. It's also worth knowing that head injury is a risk factor for dementia. So having been knocked out approximately doubles your risk of dementia. So I think that this is something that is only just becoming known in our community. You all know that now in professional sports there's a lot of emphasis on head injury in our elite competence, but I think that this is something that is worth being aware of, and certainly when my children were young and were playing soccer, I've said you mustn't ever headbutt the ball. You know, that's something that we can change. obviously you have to live life, and sometimes head injury will occur as a part of living life and part of it playing contact sport. But I think that as a society we should be minimising the risk of head injury. And so what are protective factors for dementia? We know that higher education is a protective factor. So people who are well educated have a lower age-matched prevalence of dementia than do people with lesser education. So that's something that individually we can work on, even at advanced age. There's the University of the Third Age, but certainly that's a potentially modifiable risk factor that could be applied in a broader society. We know that ongoing physical activity is a protective factor, and avoiding those other modifiable risk factors that I talked about. So, can anything be done to reduce risk? It's a very emphatic yes. And so I want to have you take this message away. I graduated from medicine in 1984. At the time when I graduated, then the story went along the lines of, if you have an injury to a nerve in your arm or your leg, the peripheral nervous system, the nerve could regenerate. If you have an injury to your brain, you're buggered. That it was believed that the brain could not regenerate. But we don't believe that anymore. So there's this whole science of neuroplasticity. We now believe that it is possible for the brain to change during adult life, and I'm going to talk a little bit more about that. So this is an evolving story. Our understanding of the situation now is much different to what it was, well, certainly during my professional lifetime. So I'll first start by asking, can the brain be made better? And I just want to refer to one really interesting research project reported in 2000. So this was a study of London taxi drivers. To become a taxi driver in London, you have to learn the geography of London, and it takes about 2 years to train up to be a taxi driver in London. And so these taxi drivers need to learn how to navigate in a very complex environment. And so the really smart researchers thought, well, let's see if the taxi drivers' brains are different from people who don't have to have really, really great navigation. And lo and behold, they found that the area of the brain that is involved in navigation is bigger in London taxi drivers than in comparable subjects. So that shows you that, and there's one other little piece of information. Not only is it bigger, but in taxi drivers who've been driving a long time, it's even bigger than in taxi drivers who've been driving a short time. So it tells you that these taxi drivers had trained up their brains. Their brain had physically changed. It had grown, it had actually physically grown through the mental effort that was required of them. So this is evidence that you can make a better brain. This is like you're going to the gym and getting better muscles. You're working on your brain, you can get a better brain. And this is really important because this is a very different story to what was broadly believed just a few decades ago. Second, can the brain be made stronger? And so my colleagues, Nicola Lautenschlager and Leon Flicker, did a really elegant study in Western Australia where they had people with early very, very, very early signs of cognitive impairment, so not yet dementia, but mild cognitive impairment. And these people, they randomized to a walking program 3 days a week versus usual care. And lo and behold, after 18 months, they could measure a difference. They could measure better thinking in people who are regularly walking compared to those who weren't. I think that's a fantastic story. This tells you that being active is good for your brain, and it turns out that our body, God or nature, depends on who you believe, how you believe we were created, were very economical, and so the molecules that were used to make your muscles stronger, which are liberated when you exercise, also happen to make your brain stronger. Those transmitters get used in the same. Those same transmitters get used in different places. So exercise doesn't just make your body stronger, but it makes your brain stronger. And this is local research. And my next question is, can brain exercise delay dementia? And this is absolutely hot off the press, published 28th of January this year. My colleague, Professor Henry Brodati, and a very large team of really eminent researchers from all over Australia, but this is based in Australia. These researchers presented a online intervention. So this wasn't even a face-to-face intervention. This was an online intervention. And you can guess what they talked about, and I'll just read it out for you. They talked about the physical activity intervention module delivered personalised messages and advice in response to an individual's progress towards physical activity goals. Training consisted of individually tailored feedback and goals for progressive aerobic training, 300 minutes at moderate intensity or 150 minutes of vigorous intensity per week, strength training, 3 or more days at vigorous intensity per week, and balance training every day. So that was the advice they provided, online advice. They also provided nutrition advice, and guess what? Nikki could have provided that for them. The nutrition intervention module specified and supported personalised goals aimed at improving adherence to a traditional Mediterranean diet pattern, which you just heard about. They had a brain intervention module, 3 times per week, approximately 45 minutes per session, across the first 10 weeks, and then monthly. They basically played online games. So these were verbal, executive, verbal memory, visual executive, visual memory, visual attention, speed, and working memory. And then they had a peace of mind intervention module aimed to reduce depression and anxiety. They also had a smoking cessation advice, and they had an alcohol reduction advice. So that was their intervention. And you know what? At 3 years, they could measure a difference. So I think that this is really, really, really good news. So in summary, I just want to conclude saying that dementia is a common disease of older people. It's not normal aging. We now have good evidence that people can reduce their personal risk of dementia. And guess what? It's use it or lose it. You've heard that before. Good, clean living, right? No smoking, limited alcohol use, and good social contact will reduce the likelihood of dementia or the progression of cognitive impairment. Thank you very much.